So today I will be discussing about the basics of CRRT. CRRT is defined as any extracorporeal blood purification therapy intended to substitute for impaired renal function over an extended period of time and applied for or aimed at being applied for 24 hours per day. So then the question arises why we have to do the CRRT instead of just going for say hemodialysis. So basically it closely mimics, not exactly, but it closely mimics the native kidney in treating the acute renal failure and fluid overload. It removes large amounts of the fluid and waste products over a period of time. Most important is it is tolerated well by the hemodynamically unstable patients. Like in hemodynamically unstable patients, we cannot do the hemodialysis. So wherein CRRT works well. So the treatment goals are, it maintains the fluid, electrolyte, acid-base balance. It prevents further damage to the kidney tissue, promotes healing and total renal recovery, allows other supportive measures, that is nutritional support, drug delivery. So potential applications of the RRT are, basically it is divided into main two components, that is as a part of renal replacement, the other one is renal support. So renal replacement is the traditional approach when little or no residual kidney function is present. In that, the most important is life-threatening indications, like wherein you have to do immediate CRRT. For example, hyperkalemia, refractory acidemias, metabolic acidemia, pulmonary edema, uremia, which leads to pericarditis, bleeding, myopathy. The third one is non-emergent conditions like solute removal, solute control, and fluid removal. So as a part of renal support, wherein sometimes with excess of fluid overload, or suppose you are giving some drug which is, like nephrotoxic, there also you can use which can cause decreased kidney function. Also you can use the CRRT. So for example, as a part of volume control, when you are using lot of fluids intraoperatively, say liver transplant patient, or sometimes in cardiopulmonary bypass and ECMO, here also you can introduce the CRRT filter into the circuit itself. And when you want to give the nutrition and the patient volume status doesn't allow you to give the proper nutrition, there also you can consider the CRRT. And as a part of drug delivery, hypernatremia, sometimes refractory hypernatremia, wherein there is associated fluid overload also, there also you can do the CRRT. Hypercapnic acidosis. As part of solute modulations like tumor lysis syndrome, cytokine removal in sepsis. These are some non-renal indications for CRRT like fluid overload, anticipated large transfusion in trauma or coagulopathy, inborn error of metabolism, sepsis, post-cardiopulmonary bypass, surge response, pancreatitis, and drug overdosage. So the role of CRRT in acute renal failure is basically it removes the toxins, urea and creatinine, regulates the electrolyte and water balance, regulates the acid-base balance, prevent further damage to the kidney tissues. It promotes the healing and renal recovery. Basically, it acts as an artificial kidney when the kidney is damaged. The role of CRRT in sepsis, actually it is very much controversial whether the CRRT machine will remove the inflammatory markers. But still, if you just go theoretically, like all these inflammatory markers are middle to large molecules. It comes at the lower side of the middle molecules, means they are little larger molecules, though they are not classified under the large molecules, and all the large molecules are under the inflammatory markers. So if you speak theoretically, CRRT can still remove all these inflammatory markers, but there are some but exactly we don't know whether it will change the outcome. So other roles are removal of the excess fluid and waste products, maintenance of the acid-base balance. It improves basically cardiovascular hemodynamics. removal of the cardiodepressants and thermoregulation, but only if you do with the warmed fluids. Other role of CRRT is for rhabdomyolysis. It maintains the fluid electrolyte, prevents further damage to the kidney tissue. It removes small to middle protein molecules, that is up to 17,000 Dalton, through convection. It may cause the nuisance blood alarms. It is important to keep it in mind that CRRT machine has got a blood leak detector. So suppose if something which stains the effluent, like hemoglobin, myoglobin, vitamin C, B12, all these things can cause the alarms. In this case, you have to mute the alarm. So in hepatic failure, which is characterized by ascites, coagulopathy, multi-organ dysfunction, elevated bilirubin, hypomagnesemia, with increased ICP or cerebral edema, there is definite role of CRRT. So in ALF, indications are renal dysfunction. When the patient is having oliguria, anuria, hyperkalemia, fluid overload, obviously you have to go for the CRRT. And hyperammonemia, ammonia more than 150 and not getting controlled, absolute value of more than 200. Hepatic encephalopathy more than grade 2. Metabolic abnormalities like hyponatremia, high lactates, refractory acidosis. It is important to remember here that no one indication is an absolute indication to do the CRRT. So it is most important that it is performed as soon as the patients display the severe metabolic disturbance, that is metabolic acidosis, lactic acidosis, hyperammonemia, vasoplegic hemodynamic profile, and hepatic encephalopathy greater than grade 2, irrespective of the renal function. You have to do the CRRT. In fact, it is mentioned as before the AKI kicks in. So in one of the article in hepatology, it is mentioned that CRRT, in this study, it is a large cohort study wherein CRRT was associated with reduced serum ammonia levels and mortality in acute liver failure. So the conclusion of this article was, in a large cohort of ALF patients, hyperammonemia was associated with high-grade hepatic encephalopathy and worse 21-day transplant-free survival. And CRRT is associated with a reduction in the serum ammonia level and improvement of the 21-day transplant-free survival. So what are the options available in ALF as a part of renal replacement? So you can go for a high-dose CRRT. Usually 35 to 45 ml per kg per hour we do in case of CRRT. Here it is up to 60 ml per kg per hour can be done. MARS, that is molecular adsorbent recirculating system using the albumin. Third one is plasmapheresis. And it is important to remember here that plasmapheresis is one of the modality in ALF where it will improve the synthetic function, but it cannot replace the CRRT. And sometimes the ammonia can rebound. So sometimes we have to supplement with the CRRT after the plaques. So with the invent of HVVH, that is high flow veno-venous hemofiltration, it has replaced the MARS. Reasons being, it is convincing results obtained in ammonia detoxification, neurological improvement, electrolyte homeostasis, and hemodynamic stabilization. And to some extent, it combats the cytokine-induced vasoplasia. So how does the native kidney removes the solutes and water? Each kidney has approximately 1 million nephrons. The complex glomerular filter is both size and charge selective. It allows free passage of solutes less than 50,000 Daltons. So if you just see 50,000 kilodaltons, which means it covers almost all of the small molecules and the middle molecules, except the large molecules like hemoglobin, tumor necrosis factor alpha. These things are not allowed through the native kidney. The glomerular basement membrane is negatively charged and it tends to repel the negatively charged particles while allowing the easy passage of the neutral and positively charged particles. So how does it performs its job? The hydrostatic pressure necessary for producing an ultrafiltrate is provided by the mean arterial pressure in the afferent arteriole. Concentration gradient. So for example, this is replaced by the blood pump in the CRRT circuit. Am I audible, ma'am?
Yeah, you are audible.
Okay. The tone of the efferent arteriole provides the resistance to the outflow. For example, membrane and pores in the hemofilter of the CRRT. The net result is positive, resulting in the production of GFR at 100 to 120 ml per minute, leading to the formation of 144 liters of the ultrafiltrate daily. If you compare, this is no equivalent to the CRRT machine, wherein it hardly performs the 1/3 work of the native kidney. The real brain of the kidney is the renal tubule, which alters the ultrafiltrate to meet the homeostatic needs of the body. Reabsorption, secretion, concentration, and diluting mechanisms by the different segments of the renal tubule produces a final urine, which is 1% of the primary ultrafiltrate. So the question comes whether CRRT replaced the function of the native kidney. Answer is definitely no, both in terms of quantity and quality of the ultrafiltrate. So if you, before going to the discussion about the CRRT machine, how does it work, the mechanisms like diffusion, convection and all, I just would like to show you the basic ECOST circuit, that is extracorporeal organ support therapy circuit, which basically contains, from the patient you have a double lumen catheter, and there is a roller pump, then comes the hemofilter. From the hemofilter it goes to the patient. So from the patient through the roller pump, which is mentioned, the first one, I don't know whether you can see that whether there is no pointer here. Yeah, this one is the, sorry, this one is the roller pump, that is blood pump. Basically it acts as a hydrostatic pressure which draws the blood from the patient and sends it to the hemofilter. Okay, in this hemofilter there is diffusion, convection, ultrafiltration, adsorption. All these things are going on based on the modality you choose. Okay, this is the roller pump for the effluent. Means whenever there is a hydrostatic pressure applied from this roller pump, that is blood pump, this effluent pump draws the blood to the effluent bag, that is the waste products are collected here. So it acts as a, this is a pressure applied, and the filtrate is collected in the bag, effluent bag. So from the hemofilter, the once it is based on the mechanism you have chosen, CVVH, CVV, HDF and all. So the remaining, whatever the purified blood is, returned to the patient. So here is the replacement fluid. This replacement fluid is Prismosol, that is in CVVH, or it can be as a dialysate, which we use in cases, all modalities of the hemodialysis, SLED and all. So what are the mechanisms of solute and fluid removal in the artificial kidney as well as native kidney? So we divide it into mechanism for solute removal and mechanisms for the fluid removal. For the solute removal, it is the one is diffusion, which is nothing but the solute moves from the higher concentration to the lower concentration through a concentration gradient. This is in case of peritoneal dialysis, all modalities of hemodialysis and hemodiafiltration. Basically, it is, I will come to that. Convection or solvent drag or bulk flow means the solute molecules just move passively along with the solvent. through the transmembrane gradient, which is produced by the hydrostatic pressure between the hydrostatic pressure from the blood pump to the hemofilter. So the modalities are SCUF, CVVH, and the native kidney. Basically, convection is the main mechanism for solute removal in native kidney. Then comes the adsorption. This is nothing but sometimes the larger molecules will get adhered to the, say, more than 50,000 Dalton. They will get adhered to your filter. But some specific filters are available, like polymethyl methacrylate, oxyrase. All these help in removal of the larger molecules. For example, say cytokines. So, but the drawback of this adsorption mechanism is this is effective in the initial phases of the when the circuit is fresh. Once the membrane is saturated with the larger molecules, it no longer helps in adsorption of the fresh molecules. The fourth thing is the osmosis, that is mainly in peritoneal dialysis. Here, the water moves from the lower solute concentration to the higher solute concentration. And mechanism of fluid removal is basically by the ultrafiltration or hydrostatic pressure. So this is the modality in all the CRRT techniques, as well as peritoneal dialysis and the native kidney. So this is the diffusion, wherein the molecules move from the higher concentration to the lower concentration. So this is very important. Rate of diffusion is influenced by size of the solutes. That is, basically, it will help in removal of the small molecules, say like less than 500 Daltons. So that is urea, to some extent creatinine, and all the electrolytes. Pore size in the membrane, that is good clearance of the small molecules compared to the middle molecules. Basically, the filter has a small pores compared to the hemofilter used in CVVH. So basically, so it is a good clearance for the smaller molecules compared to the middle molecules. And most important is concentration gradient. Always you need a gradient wherein the inflow fluid should have a more concentration compared to the dialytic fluid or replacement fluid. If the concentration gradient is not much, soon the molecules the concentration will get equalized between the two compartments and diffusion may not take place. And also depends upon the blood flow rate, dialysate flow rate, and type of the filter. Coming to the convection and ultrafiltration. So convection is nothing but solvent drag, or it is a bulk flow. Here the main mechanism is just there is a hydrostatic pressure which draws, which is in case of CRRT machine, the blood pump, roller pump, which brings the blood from the patient. And there is a, I'll come to that. So transmembrane pressure gradient between the hemofilter and the ultrafiltrate collection bag, that is effluent bag. So in this, solutes are removed by the flow of the solutes along with the flow of the solvent, not influenced by the size or concentration of the solute. So it is different from the diffusion mechanism. It also depends upon the pore size of the membrane. So here the hemofilter has a comparatively larger pore size compared to the diffusion, that is a hemodialysis filter. Small solute clearance is less than in the diffusion. So coming to the squeezing ultrafiltration. So convection, actually the convection and the ultrafiltration go together. Means the convection is mainly for the transfer of the solutes. So which is actually happens by the ultrafiltration. Means along with the water, the fluid, the solutes are moved because of the solvent drag. So if you can see these arrow marks, okay, here there is a hydrostatic pressure, say the roller pump in the hemofilter, just before the hemofilter, which helps in creating the hydrostatic pressure. So once you apply the pressure here, there is a movement of the water, like a squeezing of a tea bag. Since you are moving, since there is a movement of the water, some of the middle molecules and most of the middle molecules and some of the smaller molecules move along this gradient created between pressure gradient created between the two compartments. So ultrafiltration is nothing but it is equated to the squeezing of a tea bag. The pressure for the ultrafiltration is provided by hydrostatic pressure in the arterioles, that is mean arterial pressure in the normal kidney, and blood pumps in the CRRT. And in case of peritoneal dialysis, it is the osmotic pressure exerted by the glucose in the PD fluid. For example, if you go on increasing the glucose concentration in the PD fluid, we say we start with 1.5 and you can go up to 3.5. So once you increase the glucose concentration, there is movement of the water from the patient to the effluent bag. So ultrafiltrate has limited solute removal. For example, when you are doing the scuff, that is only for the fluid overload patients, there is hardly any removal of the solute. So coming to the vascular access, important to remember is it is a double lumen stiff catheter compared to the what we use for the CVP line, and it has got two ports. That is, a red one is the access port and the blue one is the return port. So if you see the red access port, that is the inflow cannula, is the distal single hole. Whereas the blue one, that is the return port, which returns to the patient, is nothing but it is the side holes. So, but when there is a problem with the drainage, say there is a drainage is not happening properly, then sometimes you can reverse these cannulas. Means red color one can act as a access return port, whereas blue one can act as a access port. So location, a veno-venous double or two single lumen venous catheters. So you can use, best one is the internal jugular vein, right one. Basically, it has got a lower risk of complication and simplicity of catheter insertion. Femoral vein, it basically optimal site for immobilized patient, and it is the easiest site for insertion. Subclavian vein has got a higher risk for pneumothorax or hemothorax, and it is associated with the central venous stenosis. So studies by Hackberth et al. Have identified that in children, improved outcome as measured by circuit life is greater with the internal jugular placed catheter compared to a subclavian or femoral catheter. So ideal site is, most ideal one is the right internal jugular vein, if not femoral, if not left IJV, if not, you can go for a dominant site subclavian. Avoid the femoral access in future kidney transplant patients to avoid the stenosis of the iliac veins. So based on the age of the child, you can select the catheters. In neonate, we will usually go for a single lumen 5 French or dual lumen 7 French. And the catheters are available up to 12.5 French. So the contraindications for CRRT are very few contraindications. Even in the presence of intracranial hemorrhage, systemic bleeding, CRRT can be performed by using no anticoagulation or regional citrate anticoagulation. Some experts say intracerebral hemorrhage is the absolute contraindication. Thank you.